Hello and welcome back to Clinical Cases. Today we're going to be continuing to look at the urogenital block. This is part 3 of 4 and we will be covering conditions such as overactive bladder, stress urinary incontinence, precocious puberty, testicular swellings such as hydroceles, spermatoceles, varicoceles, testicular cancers and tumours, foreskin disorders such as Phimosis and Paraphimosis, congenital adrenal hyperplasia, Hemaphroditism, female genital tract abnormalities concerning Agenesis and Septum, and Andropause. So let's begin by looking at overactive bladder syndrome. So this is a common condition that affects millions of people. It isn't a disease, it's simply the name of a group of urinary symptoms. The most common symptom of an overactive bladder is a sudden urge to urinate that you can't control. So some people will leak urine when they feel the urge, and leaking urine is actually called incontinence. So having to go to the bathroom many times during the day or night is another symptom of overactive bladder. In terms of management, this can be down to lifestyle modifications, so for example restricting the amount of fluid you drink, avoiding drinks such as caffeine which will make you need to urinate more frequently. However, usually these are treated with medication. So if you think about it, it's an overactive bladder, the bladder muscle is contracting too much, so therefore you may treat it with antimuscarinic drugs or beta-adrenergic agonists. There are also medical procedures that you can undergo, such as Botox, to change the bladder in order to make it less active. Patients may also wish to attempt bladder drills or bladder training in order to slowly stretch the bladder over a period of time in order to allow it to hold a larger volume of urine. There are complicated causes of an overactive bladder syndrome, including a stroke, Parkinson's disease, and a spinal cord injury. Next, we were taught about stress urinary incontinence. So this is when urine leaks out with sudden pressure on the bladder and urethra, causing the sphincter muscles to open briefly. With a mild SUI, pressure may be from sudden forceful activities such as exercise, sneezing, laughing, or coughing. However, if your SUI is more severe, you may also leak with less forceful activities like standing up, walking, or bending over. It's important to be able to distinguish between what we've just discussed in terms of an overactive bladder and a stress incontinence. So an overactive bladder is an involuntary contraction of the bladder muscle, which causes you to release urine but require you to go and urinate more frequently. It doesn't have to be alongside a leak. However, a stress incontinence is when there's actually a physical leak as a result of an activity. This is usually diagnosed by a physical examination or a cystoscopy, also potentially by a bladder diary or history, allowing the consultant or doctor to understand how frequent the patient goes to the toilet and if this is normal for them. In terms of treatment, behaviour changes, weight loss, pelvic muscle exercises, and electrical stimulations tend to be the easiest ways to treat this condition, as surgery is a lot more invasive. This condition usually does occur following childbirth, so with women who've undergone pregnancy and delivery and a vaginal delivery of the baby, they tend to have poor function of the pelvic floor muscles and the sphincter due to the tissue or nerve being damaged during the delivery of the child. Next, we looked at precocious puberty. So this refers to the appearance of physical and hormonal signals of pubertal development at an earlier age than is considered normal. Essentially, a long time ago, puberty was considered precocious in girls younger than 8 years old. However, recent studies have indicated that signs of early puberty, such as breasts and pubic hair, are now often present in girls aged 6 to 8 who've developed precocious puberty. For boys, it's the onset of puberty before the age of 9 years old, so that's a slightly higher age than that of girls. This can be broken down into two categories, so you can have central precocious puberty or peripheral precocious puberty. And the difference in these is in terms of the cause. So central is related to the hypothalamic pituitary gonadal axis being activated, or it could be idiopathic, or it could be a CNS lesion. In terms of peripheral precocious puberty, this could be down to CAH, so congenital adrenal hyperplasia, or it could be down to ovarian cysts, tumours, hyperthyroidism. The causes are a little bit more broad. Symptoms, as we mentioned, for girls, you'd expect breast growth or a first period earlier than expected. However, for boys, it would be down to enlarged testicles and penis, facial hair, deepening voice, and acne. Moving on, we looked at testicular swelling, so the three main ones that we need to be aware of are hydroceles, spermatoceles and varicoceles. So, a hydrocele is a type of swelling in the scrotum that occurs when fluid collects in the thin sheath surrounding the testicle. A hydrocele is common in newborns and usually disappears without treatment by the age of 1. Older boys and adult men, however, can develop a hydrocele due to inflammation or injury within the scrotum. So important differentiation there is that it can be congenital, but it can also be acquired. It's diagnosed through a careful history, understanding that the patient's had a slow growing lump, and also through examination where you'd expect it to be transilluminant. A spermatocele or epididymal cyst is a painless, fluid-filled cyst in the long, tightly coiled tube that lies above and behind each testicle. The fluid in the cyst may contain sperm that are no longer alive, and it feels like a smooth, firm lump in the scrotum on top of the testicle. And this condition is normally diagnosed via an ultrasound scan. Lastly, we have varicoceles. So this is when veins become enlarged inside the scrotum. These veins are called the pampiniform plexus. It presents in around 15% of males and in around 30% of subfertile males. However, having said that, the majority of them are asymptomatic, but they usually present with a lump or potentially reduction in testicular size as well. And this can be graded. In terms of investigations for this condition, you'd look at ultrasound scans or semen analysis. The pictures down the side illustrate the difference between looking at these testicular swellings on a normal diagram and also looking at them on an ultrasound, which is usually the way that they are diagnosed following examination. And it's important to be aware of what you're looking for on the ultrasounds also. Next, we were taught about testicular cancer or tumours of the testicle. So more than 90% of testicular tumours arise from the germ cells. So testicular germ cell tumours can be subdivided into seminoma and non-seminoma germ cell tumours. Of the germ cell tumours, around 50% are seminomas and 50% are non-seminomas. So this is highlighted at the bottom, the difference between the two. The non-germ cell tumours include Leydig cell tumours, Sertoli cell tumours and sarcomas. And since the introduction of combination chemotherapy in the 1970s, survival rates for testicular cancer have been really quite high. So it's around a 95% survival rate for testicular cancer. However, it can have long-term implications in terms of if the testing needs to be removed. Moving on, we looked at foreskin disorders. So first of all, it's important to understand the normal anatomy of the prepuce or the foreskin. So it's a double-layered fold of cutaneous tissue with skin on the outside and mucous membrane on the inside. It's richly innervated and it's very vascular. It covers and protects the glans penis and the urethral meatus. At birth it is normally attached and therefore it won't freely retract until around the age of 7. However, understanding the normal anatomy of the foreskin will allow you to understand the following three conditions. So phimosis is a condition in which the foreskin of the penis will not retract back past the glans. So, as we said, this is normal up until the age of around 7 years old, and after that it can be kind of considered as a condition of phimosis. Normal causes of this include eczema, psoriasis, lichen planus, or lichen sclerosus. The symptoms could include pain during intercourse, potential bleeding, tear of the frenulum, pain in the foreskin, or difficulty urinating or having a weak flow. However, these aren't all applicable to the condition, so you may only experience one or two of these. Sometimes it can be asymptomatic, in which case no treatment is needed, maybe steroid cream to help the foreskin retract. However, circumcision is kind of the last stage in order to reduce the impact on the patient's life. Paraphimosis, this is an emergency when the foreskin is retracted beyond the glans penis and it is unable to return over the glans penis. Balanoposthitis is inflammation of the glans penis, and when the foreskin is also affected, it is then termed Balanoposthitis. Next, we looked or were taught about congenital adrenal hyperplasia. So this is a slight overlap with the endocrine block because it relates to hormones. So congenital adrenal hyperplasia are any of several autoimmune recessive diseases resulting from mutations of genes for enzymes mediating the biochemical steps of production of the mineralocorticoids, the glucocorticoids, the sex steroids, which are produced within the adrenal glands. So most of these conditions involve excessive or deficient production of sex steroids and can alter the development of primary and secondary sex characteristics in the affected infants, children or adults. It's important to be aware of the normal adrenal gland function, so how you've got the cortex and the medulla, and what each layer, the zona glomerulosa, produces the mineralocorticoids, the zona fasciculata produces the glucocorticoids, and the zona reticularis produces the androgens. The easy way to remember this I find is GFR, so you'd associate with GFR with the kidneys anyway. The adrenal glands are on top of the kidneys, and so the three layers of the cortex from outside to inside are GFR. The symptoms that you'd expect a patient with congenital adrenal hyperplasia to have are potentially salt wasting, a rapid growth, precocious puberty, short stature. You'd also potentially expect them to be scanty as well. It does have a relevance to disorders of sexual differentiation, which is how you link it into the urogenital block. Being aware that 70% of those disorders of sexual differentiation is actually down to congenital adrenal hyperplasia. Hemaphroditism is what we'll talk about next. So this is where the patient will have ovarian as well as testicular tissue. It's inherited in an autosomal recessive manner. The diagnosis has traditionally been applied only if the individual has both of the histologically verified ovarian follicles, or proof that they have existed in the past, as well as seminiferal tubules or spermatozoa. It's quite a rare condition, and there's several ways that it can occur, which really come down to the fertilization of the ovum by the sperm. Next we have female genital tract abnormalities. So I've split these up into agenesis and septum defects. So agenesis, you can have a Müllerian agenesis, which is where the uterus is not present, and the vagina is only rudimentary or absent, and it's a congenital malformation that occurs during within the embryo. Cervical agenesis, so if you get the impression that agenesis means it's not present, so a cervical agenesis is when the cervix is not present, or it could be deformed or non-functional. Also, you've got septum defects, so you can have a longitudinal vaginal septum or a transverse vaginal septum. A longitudinal vaginal septum develops during embryonesis when there's an incomplete fusion of the lower parts of the two Müllerian ducts, and a transverse septum can form during embryogenesis when the Müllerian ducts fuse inappropriately to the urogenital sinus. So essentially these are all embryological malfunctions, the agenesis and the septum, that have gone wrong. They're congenital diseases or disorders. Last of all for this video, we're going to look at andropause, or also called late onset hypogonadism. So essentially this is referred to more commonly as the male menopause. It describes age-related changes in the male hormone levels of testosterone. The same group of symptoms is also known by other names such as testosterone deficiency, androgen deficiency, and late onset hypogonadism. And when we say age-related, we're referring to those men who are aged 50 or over. And approximately around 30% of these men who are 50 and over will experience symptoms at some point of the andropause. These symptoms are erectile dysfunction, low sperm count, depressed mood and decreased libido. Also they may experience lethargy and hot flushes, so some crossover symptoms with the female menopause. A diagnosis really comes from a careful history, understanding the symptoms that the patient is going through, and from there ordering a blood test to check the testosterone levels. The treatment for this condition really comes down to replacing the testosterone that is no longer present in these males. So this can be done either by skin patches, gel, capsules or injections. Referring to the cause of this disorder, it's fairly normal for testosterone levels to decrease with age in both men and women. However, the causes aren't well understood. There are some links to the fact that the body makes less testosterone as you get older, but more sex hormone binding globulin, which attracts the testosterone that's free in the blood, the testosterone that's bioavailable, and therefore because that's binding to that free testosterone, there's less bioavailable testosterone in the blood, and that's kind of the physiology behind it, why it happens, but in terms of the cause, it's not really well understood. That's everything for this video. There's one part left of the Urogenital series where we'll cover the remaining 10 cases that we were taught about in the Urogenital block. As always, if you do have any feedback or any questions, that's greatly appreciated. Please do leave them in the comments below. Please like the video to show your support. And that's everything. Thank you very much.